We need to redefine that it's like, I'm sorry, 90% of your time, men should be spent on the women's clitoris and not having intercourse. Not having penetration. But
there you go.
So, yes.
Welcome to Becoming Virtuosa, the podcast with Dr. Susan Crockett. You are listening to episode number 54, Two Gyns, Real Chat, Let's Talk About Sex, Baby. An interview with fellow board-certified OBGYN and the director of the Brooke Army Medical Center OBGYN Residency program. Please welcome Dr. Erin Keyser.
Welcome to Becoming Virtuosa, the podcast that encourages you to become your best virtuosa self. Each week, Dr. Susan Crockett goes where the scalpel can't reach, exploring conversations about how to be, heal, love, give, grow, pray, and attune. For the first time ever, she's bringing the personal one-on-one teaching that she shares with individual patients to you on this broader platform. A weekly source of inspiration and encouragement designed to empower you. By evolving ourselves as individuals, we influence and transform the world around us. Please help me welcome board-certified OBGYN specializing in minimally invasive GYN surgery, internationally in the top 1% of all GYN robotic surgeons, a certified life coach, and U.S. News top doctor, your host, Susan A. Crockett, MD.
We have my amazing guest, Dr. Erin Keyser, with us today from Brooke Army Medical. And we are two OBGYNs in San Antonio, Texas. What could go wrong? What could go wrong with this conversation? What could go right? We're going to talk about sex, you guys. This is going to be really fun. Hang on to your hat. So what are we calling this?
Let's talk about sex.
So if you haven't seen part 1, I'm going to have you go back and listen to part 1. We're not going to do a whole big introduction again, but basically Dr. Keyser runs the OBGYN residency program at Brooke Army Medical Center. And I proctor her residents. I work as one of their local non-military physicians, and they come and learn surgery from me, robotic surgery. So that's how we know each other. You got a little disclaimer.
Oh, yeah. So I am in the military. So I need to say that the views expressed today are of mine and not of the military or the Department of Defense or any of those things.
Yeah. And neither one of us have any skin in this game about any of this. We're not selling any sex products.
We're not selling anything.
Promise that's not the way my GYN practice runs. I have friends who do that.
But we're probably going to use real terms because I remember my husband's not medical, and the first time we were out to dinner, he's like, you just can't be saying vagina all the time. I'm like, why
that's
not?
That's just a normal word.
So we might be using a lot of terms.
Yeah, but because we're doctors, we're going to use the regular terms. We're not going to throw in hoo-ha. You can't say that. No,
we're going to use vagina and vulva and clitoris.
Okay, got it. All right, so we are kind of dovetailing this conversation off of the prior one that we just had, which is about menopause and menopausal transition, hormone therapy, and we kind of got a little into taking care of the vagina as we go through menopause.
Well, I think it's a good segue because when we look at the incidence of sexual dysfunction, it usually peaks at menopause, right? As the hormones are changing. That's kind of the time when sexual dysfunction in women kind of peaks. And so they do kind of correlate together.
Yeah. So we get vaginal dryness, so it becomes painful. We get fatigue, so we don't have as much libido. We're not sleeping as well. We're hot and sweaty, hot flashing anyway.
Not feeling super sexy.
Putting on weight. Yeah, so it's peaking about this midlife time.
And I mean, other big times are postpartum, right? Because you're sleep deprived from having a baby at home and you're breastfeeding and you maybe just had a tear.
Yeah.
So that's another time where we see a lot of sexual dysfunction.
Yeah. And then our male counterparts, for those of us that are in heterosexual relationships, they're also seeing testosterone decreasing. But from my side of my practice, I'm seeing a lot of women coming in with their partners being on more testosterone and Viagra and all of these enhancers. And they're like, give me something. Right?
Well, and it's a sad state of affairs. I mean, there's I think over 100 FDA approved products for men's sexual dysfunction, and there's 2 for women. It's a very unfair market out there.
What the heck?
Yeah. It's we need to pay attention to women's sexual function. Yeah.
Yeah, we do.
Yeah.
So that's what we do.
Yeah.
So you do more on the hormonal side because you're one of the Menopausal Society people. We'll link that here like we did in the other one. For me, it's more surgical. They come in needing surgery for uterectomy. That's what we're calling hysterectomy now.
Yes.
Or they have prolapse issues, bladder issues, and I'm doing
surgery,
reconstruction to fix it. And they're like, how can I maintain sexual function?
It's going to change my ability to have sex.
Yeah. So that I pay attention to that. Even, it used to surprise me when patients that were in their upper years, 70s and 80s were concerned about that. But now I just expect it. Everybody gets the question asked about whether, what this is for a priority for them. Yes. And there is a way more sexually active octogenarian, is that how you say it?
I don't even
population,
yes.
people in their 80s than I ever would have imagined when I was just starting my practice.
When I'm 80, I'm still having sex.
Right? That's a lovely thought, isn't it? So tell me a little bit about how you handle patients coming in during this time.
I feel like there's been a big push maybe in the outside the media. I definitely feel like there's a lot more patients coming in with low libido or saying they have no desire and they want a pill for it, right? Or they want like a magic pill. And I think it's really common. I think if you take all comers, probably 60% of women would say they have, less desire than their male counterparts or their men. I think there's a small percentage of people who probably actually have like a true like pathologic or physiologic issue. I think just in general, women and men, sexual drive and sexual desires just are very different. Like men, it's a very linear thing. Like they might see a magazine with a bra and they're horny. Yeah. But women, it's like most women are not just like horny every day. They're not the Samantha on Sex and the City thinking they're like, they want to have sex all the time.
I heard somebody talking, it may have been a podcast I recently heard, and I'm sorry, I can't remember who it was right now, but they were talking about that men have just that direct like sight to desire, and women have two different levels of arousal. And one of them can be that sight to arousal, but the other one is much more subtle and takes time and thinking about it, pondering it, going over and over it, and feeling safe. That was a really big thing.
Yeah, because if you think about it, you're like, well, do I want to have sex? Well, was my partner helpful? Did they help with the chores or the dishes? Or, are my kids home? Or there's so much like kind of super tentorial, like in our heads, like we have to feel safe. We have to feel like respected. We have to feel, if I'm feeling overweight or fat or whatever, I'm not going to feel sexy. And so there's so much more that like you have to feel self-confident. You have to feel respected and safe by your partner. I mean, there's so much that goes into it. So there's no like magic pill. And people are like, can I take Viagra? I'm like, well, Viagra gets the man an erection. It gets blood to his penis, but it doesn't actually make him horny. Like it just allows him to have an erection.
It's just supporting the horniness he already has with the end organ function.
Yes.
There you go.
And so people are like, oh, can I take Viagra? But it's like, well, that doesn't really work. So there are some medications that have come out that are FDA approved, and there's some that are non-FDA approved and, supported by different organizations. But most of the time, I would say for the majority of women, they don't need medication. That simple things like communicating with your spouse. There's a great book written by a sex therapist called Come As You Are. COME, Come As You Are.
I love that.
And she talks about how everyone has accelerators and brakes, right? In general, like for generalizing, men have more sensitive accelerators, right? They see a bra and they're like, oh, and women tend to have less sensitive accelerators and more sensitive brakes. And so you need to identify what are your accelerators, what gets you excited, and what are your brakes. And not just identify them, but then share that with your partner, right? So like for me, I have 2 boys at home. If my boys are home and I know they could walk in, huge breaks for me.
And
so now it's like my husband and I joke, we're like hotel sex, or like if the kids aren't home because you're like, no one's going to walk in, the breaks are gone. And so it's not, so like my husband's not like, oh, she's not attracted to me anymore. She doesn't want to have sex with me. It's like, no, I know now that when the kids are home, she's just like, that's a turnoff for her. And so just be able to communicate that. And then the other thing is like sometimes just reading erotica. Sometimes it's as simple as that, reading, watching a movie. And it doesn't have to be like hardcore porn, but just like a little bit of erotica. And I even think like Colleen Hoover, some of these other ones, just like really subtle, but it's like enough that sometimes that's all it needs.
To get the brain going on that pathway. It just needs the little thinking about it. One trick that I had heard a long, long time ago that I've used in my practice is planning it ahead of time so that like the day before you plan time with your partner. And so the partner's already looking forward to it. But for the woman, it's especially important because then she starts thinking, what am I going to wear? Where's it going to be? And the thought that is the same kind of idea that the brain starts focusing on it, and it gives it that longer warm up that we need to anticipate and be able to enjoy it.
And a lot of women, a natural response for them is like, a lot of women, they're not like, I'm horny, I want to have sex. It's like, once we get going and we're doing foreplay, then I'm into it and then I love it, right? Yeah. And if that's for you, then sometimes it's like, you know what, you might just need to do it. I use the gym analogy a lot with my residents. Like they make fun of me, but I'll tell patients, if it's like, once you get going and you enjoy it, And then you're able to have an orgasm and you're like, oh, now I feel great. I have those endorphins.
Yeah.
Sometimes it's like going to the gym. Like, I'm not one of those people who loves to go to the gym and exercise. I exercise because I have to pass my Army fitness test. So like every morning the alarm goes off and I'm like, I don't want to go, but I put on my tennis shoes and I go to the gym, and afterwards I'm like, I feel amazing. I'm going to do this every day. Yeah. And then what happens the next day? You're like, I don't want to go. Yeah. And so sometimes it's like, you got to go to the gym with your partner twice a week or once a week. And you just got to like put on your big girl panties and be like, I'm going to go to the gym.
You know what? I'm glad you brought that up, because I've used that for a long time with my patients to help differentiate when they're having sexual dysfunction versus just this kind of midlife, not the horny 20-year-old anymore kind of thing. And the vast majority of time they'll say, oh no, it's good once we get going. And I'm like, okay, that doesn't need a medication.
Exactly.
There's not a medication that can fix that.
Yeah.
So some of the medications that I manage in my office with my patients include vaginal estrogens for atrophy. We do a little bit of testosterone, although that's not my favorite thing. I don't do that very well. I don't prescribe testosterone very often. And I wanted to know your thoughts about those along with any others. And then DHEA as an adrenal for helping with testosterone, or any other things like that that are non-testosterone things that help stimulate our androgen production from our adrenal glands once our ovaries aren't working anymore.
Yeah. So there are 2 FDA-approved medications for low libido or hypoactive sexual desire disorder.
In women.
In women, yes. And I really don't love either of them, but one is called Addyi, ADDYI, flibanserin.
We'll put that down in the show notes.
And that is a medication you take once a day. So you take it daily.
Okay. What did you say the name was?
Addyi.
Or Vanserin?
Flibanserin.
Flibanserin.
Flibanserin. Flibanserin.
Okay, that's a good one.
Flibanserin. So it's a pill you take daily. So it's a daily medication. And really in studies, it led to maybe one more satisfying sexual encounter a month. And you have to limit alcohol because it lowers your blood pressure. So you can't take a second downer. So I know when it came out, I was like, I think I'd rather drink than have sex. So that's one. Yeah. And then the other one is Vyleesi, which is, it's an injection. So it's like an auto-injector sub-Q that you take, I think an hour before your anticipated sexual encounter. So that one was more, but I also think there's probably a little bit more placebo in there, because it's if I just gave myself a shot, we're doing it.
I went to all of this effort.
I went to all this effort. I gave myself a shot. We're doing it. So that one, but that one's more like Viagra, right? You take it right before you plan to have relations. Whereas the other one, you're taking it just daily and hoping things change, So those are the 2 FDA approved. I don't know how great they are, but I totally agree. Vaginal estrogen, I think anyone going through menopause and has any vaginal dryness, without that estrogen, you lose that elasticity. I think easy. Everyone should be on that.
I don't know how you do it, but I usually have my patients use a bioidentical estrase cream or estriol if they're breast cancer survivors. And I have them do 3 weeks of daily so that it rehabs the skin. Mm-hmm. We talk about that that's what it takes to get the skin to respond with the increased blood circulation and increase the elasticity. And then I teach them about starting to do stretching exercises or dilators, or to have intercourse with, and then they go down to just using, most of the time they can get by with just a small pea-sized amount at the vaginal opening without having to use the whole applicator up inside thing. Yeah. But they just do it 2 or 3 times a day. A day. A week.
Yes.
For maintenance.
Yeah. No, that's exactly what I do. And I usually ask them, I'm there's basically it can be a cream, it can be a tablet, it can be a vaginal ring. And I usually kind of feel out their preference. Some people like the idea of the vaginal ring because then they just leave it in for 3 months. They don't have to think about it and worry about twice a week. Did I already do it this week?
Yeah.
And other people feel like the cream might be messy. Everyone's different. So I just kind of ask them which of those they want.
Awesome.
And then there's the 2 FDA approved, and then there's several non-FDA approved medications for sexual dysfunction that are supported by the American College of OBGYNs and the Menopause Society. So I feel those are reasonable things to try. But again, I think 90% of women can be fixed by just what we talked about, communication and recognition of some of these things. But if it is really affecting their quality of life, there's some other options. So Wellbutrin is an option. It's an antidepressant, but it's also been used for nicotine addiction
and overeating.
Yeah. So Wellbutrin has been shown to improve sexual desire. So that's one. The biggest medication that is associated with loss of sexual function is SSRIs, or the antidepressants.
Yeah.
So Zoloft, Paxil, Lexapro in men and women. And so if you have SSRI induced sexual dysfunction and you can't stop it because we need to treat your depression, mental health issues is probably the number one thing associated with sexual dysfunction as well.
Right.
So you got to treat that too. You can add Wellbutrin to it. And there's also been a study that showed taking Viagra, if it's SSRI-induced sexual dysfunction,
Viagra
you can
helps?
use Viagra. I think it's like you take it 30 minutes before your planned thing and it's supposed to help.
I did not know that.
Yeah, so that's listed as like a non-FDA approved option.
That's cool.
And then the last one's testosterone. So testosterone, the Menopause Society and ACOG support it in postmenopausal women. So not premenopausal women, but in postmenopausal women. Unfortunately, there's not an FDA-approved version for women, so we have to use a compounding pharmacy because it has to be made basically like 1/10 the dose of what men use.
Yep.
And so it's the 1% testosterone cream, and you're supposed to do it to do like 0.5 milligrams daily, I think is what the dose is. But you can't, like, I know HEB has compounded it for my patients.
Yeah. You know, I have a couple transgender patients who have gone male to female. So they're in menopause as women, and they've done some depot testosterone injections that are also compounded.
Okay.
So I see patients asking for testosterone for a couple reasons. One is the libido idea, but I was always taught that it only helps in like less than 50% of people. It's not like a sure thing.
Yes.
And
I mean, I can give you enough testosterone to make you as horny as like a 12-year-old boy in a locker room, but you're also going to grow a beard and you're going to have a deep voice and your clitoris is going to enlarge and you're going to probably have a heart attack and like, you're going to have lots of issues. So it's like you need to just get a small amount. And so before you start it, you need to check your cholesterol. You need to check testosterone levels. You need to check your renal function. You need to check all these things and then trial it for 6 months, follow those labs, making sure it's not harming you. And then if it's helping, you can continue it. But if it's not, then you probably should stop it.
So the other reason I see people wanting it, women in menopause wanting testosterone, is for maintaining muscle and metabolism, because our metabolism starts shifting. Yeah. And I heard a physician on a podcast the other day making the point that women are not just like men. And menopausal women are not men. We are not the same even in menopause. Yeah. And in fact, men have a dip in their testosterone, but then it creeps up as they get older into their 70s and 80s. There is no such thing in women. And we have a drastic, stop of our gonadal function. Our ovaries just quit working. That's what menopause is.
And sometimes I wonder too, like the benefits they're seeing from the testosterone. Is it the testosterone or is it the estrogen? Because I don't know if everyone knows that, but like testosterone in women is converted to estrogen in your adipose tissue.
In case you didn't have enough from your adipose tissue
and so
alone.
I find it funny. They're like, I want testosterone. Oh, I would never take estrogen. I'm like, well, you're taking, that's what you're taking. So it's like, would the estrogen itself help with your muscle tone and all that stuff that we talked? I mean, I don't know.
Yeah.
I mean, there is some evidence that like the hormones improve weight.
Yeah.
In women, menopausal women. So
yeah. So
I'm like, is it that or that? I don't know.
I'm being my own experiment here. I'm starting to do more weight training, less aerobic exercise.
Yeah.
I've been watching some JJ Virgin videos about how she's managing. She's a nutritionist that's popular online. She recommends using creatine monohydrate for muscle building. None of this has anything to do with sex other than maintaining muscle tone may make it more,
well, and the whole self-confidence,
easier to
right?
do it
like
longer.
You have to have a good body image to feel comfortable, right? If you don't feel comfortable in your own skin and you don't find yourself beautiful, like how do you expect your partner,
Yeah.
And it is like your self-talk
and it's a pretty physical activity. So
that too.
It is the ultimate physical activity. So I think as women age, that keeping the muscle tone to be able to still be fit and like how we look is an important thing, but it's also a sustainability of our function to be able to.
Yeah. Well, and for your bones, I mean, osteoporosis, bone health. I mean, having continued to do like weight bearing exercises is so important.
Yeah.
So you mentioned the other testosterone, the other androgen. So the other male hormone that women produce is the one from the adrenal gland, the DHEAS. I'm not even going to try and spell it. But there is that medication. It's called Intrarosa, and it's FDA approved for painful intercourse due to atrophy. Mm-hmm. But what's interesting about Intrarosa is the initial studies, which was not the suppository, it was like a cream, was looking at desire because it does have an androgen in it, and it actually showed improvement. But then when it went for FDA approval, they just got it approved for the painful intercourse. So I do think it has the potential to also help with desire.
Cool.
And it's like a daily suppository that you place vaginally. And it's that. But again, I think it helps the vagina because it's converted to estrogen.
Yep.
But is the androgen also helping with desire? Maybe. I mean, so all of those are reasonable options that you can try.
I think we've gotten to the end of this topic.
Yeah. But I think one other key point I just want to say is a lot of it's trial and error, whether it's with the hormone therapy or with treating sexual function. Like you maybe found a hormone patch that you feel great on, but like someone else may need to try 3 different types to see which one they have the least side effects with and which one feels best for them. And so sometimes it's like trial and error and just being patient and trying different things.
I think that's true. You know, I thought of one more thing I want to bring up.
Yeah.
So this was conversation in the operating room yesterday.
Okay.
We had a great day in the operating room. So we were talking about men taking testosterone and how there's such a drive now for men to be on testosterone in their 50s and 60s, and that the natural decrease in their sexual activity or libido that used to mirror more the women's declining in drive is now being overridden by these guys who are really heavily on testosterone. And so all of a sudden, this is the norm that they're pushing, is that there's something wrong with our female patients or with us as women if we're not like meeting them at that expectation, which is to continue like 20-year-olds up into their 60s. And I just wanted to kind of talk a little bit about that, because I see it as having created problems with how my patients are seeing themselves and their own sexuality. Is there something wrong with me?
Well, yeah. And I think a lot of the TV and the media, like they push out that we're all supposed to be super horny. I mean, they also push out that intercourse is the be all for women, when it's actually like the clitoris is where women are going to orgasm from.
Thank you.
And that's usually not touched during most people having intercourse. And so most people are not going to orgasm during sex at the same time as their partner. Like that's not reality, but that's what the TV and movies show, right? Another great book, Cliteracy, Becoming Clitorate.
I love that title.
But it's awesome. All about how, like, we need to redefine that it's like, I'm sorry, 90% of your time, men should be spent on the women's clitoris and not having intercourse. Not having penetration. But
there you go.
So, yes. So I also think if you know you're not going to orgasm because your partner just wants to have penetrative sex, then I probably wouldn't want to have any desire either. You know, it's like that's part of the whole libido desire, is like, I want to enjoy it.
Yeah. Yeah, lots to unpack here. Thanks.
So many things.
So many things. Well, thank you so much for joining me for Sexy Talk today.
Let's talk about sex.
Let's talk about sex. It was awesome. Thanks for having
thanks so much.
Good time with us on the show, and I hope you come back another time and we'll find some more.
Find something else fun to talk about?
Thanks, you guys. We'll see you next week. Have a wonderful week. Thanks for listening to this episode of Becoming Virtuosa. To learn more, come visit us at drcrockett.com. That's drcrockett with 2 T's.com. Or find us on YouTube for The Dr. Crockett Show. If you found this episode helpful or think it might help someone else, please like, subscribe, and share. This is how we grow together. Thanks, and I'll see you next week. Love always, Sue.